Hello, good morning everyone. As a part of continuous cardiac education program organized by UNMICRC, today's seminar is on management of myocarditis, which will be presented by Dr. Jayesh Prajapati sir, who is HOD and professor in cardiology and having 26 years of experience in academics. So looking forward for your kind presence. Thank you.
Good morning everyone. Myself Dr. Jayesh Prajapati. I welcome you all for our program, that is continuous cardiac education program for medical fraternity. Part of that I am going to discuss or taking a lecture on management of myocarditis, and there will be interactive session followed by this. So today myocarditis, we know that it is one of the common cardiac condition that we are facing in our day-to-day practice. Everyone, physician, nurses, everyone should know about this topic. So I'm going to give the definition of myocarditis. In 1995, myocarditis was defined by WHO and International Society and Federation of Cardiology as myocarditis as an inflammatory disease of myocardium diagnosed by established histological, immunological and immunohistochemical criteria. So we know that the healthy heart is just contained of normal myocardium, while it is inflamed heart, a little bit swollen heart, and after the inflammation, then myocardial scarring occurs, and that thickness has increased and that come down to, or sometime it can lead to the scarring and thinning of the myocardium. So we should understand the magnitude of the problem. So global prevalence of myocarditis is 22 of 1 lakh patients annually as per the ICD 9th revision classification, and it's 0.5 to 4% of the cases of prevalent heart failure are due to myocarditis. And AHA says that myocarditis is the third leading cause of sudden cardiac death in competitive athletes, and autopsy studies has also shown that myocarditis is responsible for 4 to 12% of the sudden cardiac deaths. So I'm going to introduce the myocarditis in a various forms. Myocarditis may present in acute, fulminant, subacute and chronic forms. So acute myocarditis is defined as a period of less than 1 month between symptom onset and diagnosis. Fulminant myocarditis is very severe, rapidly evolving form of acute myocarditis with associated cardiogenic shock requiring inotrope or sometimes require mechanical cardiac support. Subacute myocarditis is ongoing myocardial damage due to persistent recurrent stimulus for myocardial inflammation, and also defined as healing myocarditis if there is evidence of a previous active myocarditis at a duration of more than 1 to 3 months between the symptom onset and diagnosis. While chronic inflammatory cardiomyopathy, when the symptom continue for a prolonged period of more than 1 month, the disease process is considered to be chronic inflammatory cardiomyopathy, and there is an overlap between the definition of subacute myocarditis and chronic inflammatory cardiomyopathy. There is some overlap will be there. So how we can histologically and clinically, and how we can differentiate. So patient of suspected inflammatory myocardial disease is acute stimuli leading to the acute myocarditis, and its onset of symptom is less than 30 days, and potential fulminating presentation, need for hemodynamic support. Release of biomarkers in acute phase will be there, like troponin will be elevated, CPK-MB will be elevated. LV size on echocardiography may be normal or mildly dilated, and there may be some kind of you can say some kind of enhancement, or wall thickness will going to be increased, and there will be sign. Another important thing is when you do the cardiac MRI sequences, there will be signs of myocardial edema all over the myocardium. So late glomerular enhancement will be there. There may be in biopsy inflammatory infiltrate will be there, and there will be fibrosis may be there or may not be there. There may be some evidence of necrosis. So this is initial phase, means acute phase. The myocardium is swollen basically. While what happens in chronic cardiomyopathy or chronic inflammatory cardiomyopathy, there is persistent stimuli, onset of symptom more than 30 days, often presented with heart failure symptom. There will be release of the biomarkers, may be there or may not be there. So troponin will be like a little bit elevated, but not that much of highly elevated like acute MI. LV size is dilated. Wall thickness is often normal because inflammatory phase has gone. Signs of edema on MRI may be there or may not be there. On biopsy, there will be inflammatory infiltrate, and basically there will be fibrosis or fibrosis more, there is necrosis and some of the myocyte abnormality. You can say some form of T cell and macrophage will be low. So more or less, more fibrosis, less inflammation, chronic in chronic phase, and biomarker will be slightly raised or maybe normal in chronic phase. And of course, the histologically you can differentiate such form of myocarditis like lymphocytic myocarditis, eosinophilic myocarditis, giant cell myocarditis, and granulomatous myocarditis. So lymphocytic myocarditis associated with a range of pathogen, predominantly virus, drugs, radiation exposure, and autoimmune disorder. While the eosinophilic, basically it is due to parasitic infections, hypersensitivity reaction to various agents, eosinophilic inflammatory disorder, and rarely a neoplastic process. You can see eosinophilic myocarditis, where the predominantly eosinophilic infiltrate will be there. Giant cell myocarditis, there is idiopathic in most of the cases, but it can also be associated with certain autoimmune disorders, including autoimmune thyroid disease and IBD, means inflammatory bowel disease. While the granulomatous myocarditis, you can see in sarcoidosis. So these are some of the histologically you can differentiate these things. So which is the etiology of the myocarditis? So non-infection etiologies like toxin, anthracycline toxicity, cocaine or interleukin 2, hypersensitive reaction to the cephalosporins, digoxin, diuretics, dobutamine, sulfonamide, tricyclic antidepressant. While the immunological syndromes like Churg-Strauss syndrome, diabetes, inflammatory bowel disease, giant cell myocarditis, granulomatosis with cholangitis or means vaginal granulomatosis, sarcoidosis, SLE, Takayasu arthritis, thyrotoxicosis. While the infectious agents, viral agents like adenovirus, even recent our coronavirus also, enterovirus, herpes virus, HIV also infected the myocardium leading to the myocarditis, influenza A virus, parvovirus, and Epstein-Barr virus. While the parasites like larva migrans or schistosomiasis, bacterial agents like Borrelia species, Mycobacterium species, Mycoplasma pneumonia, Streptococcus species, T. pallidum, these are some of the parasites or the bacterial. While the protozoa like T. cruzi, Chagas disease, that also involves the heart, fungal agents like Aspergillosis, Candida, Coccidens, Cryptococcus species, Histoplasma species. So all these are the etiological agents that can cause such things. And which is the pathogenic mechanism that involved in the myocarditis and progress to the dilated cardiomyopathy. So some of the myocarditis recover and some of them progress to the dilated cardiomyopathy. So there is some patient will go the myocarditis, some will go for DCM, some will doesn't happen. So there will be genetic background, and genetic background patient develop suppose like a microbial infection or non-infection things, and they develop some autoimmune things like that, and that can damage the myocardium leading to the acute myocarditis. And some of the myocarditis they recover very well. There is nothing after that the LV function improves and patient remains normal life. While some of the autoreactive myocarditis and some of the agents and some of the genetic factors can lead to the persistent inflammation and leading to the chronic myocarditis. And that chronic myocarditis lead to the chronic microbial myocarditis, infection persists, or either immune mechanism and that inflammation persists and lead to the chronic autoreactive myocarditis, or some of the patient they progress to the dilated cardiomyopathy. So post-viral infection, acute phase, after 3 months, 6 month time, that heart dilates and becomes a dilated cardiomyopathy, and that patient late after 6 months, and then we take a history, then patient give the history of myocarditis in past. So there is some of the time course that we should keep in our mind. So acute myocarditis, as I had told, either in form of viral myocarditis, this is one example, leading to macrophage activation, myocyte necrosis, and cytokine expression, interleukin 1, 2, tumor. So there is some of the inflammatory markers that are elevated, and that can lead to the natural killer cells and some of the damage to the myocardium, and sometimes because of the inflammatory process that myocardium recovers. We have seen in COVID that some of the more immunological fighting can lead to the damage to the heart and lung. So that kind of fight goes on, and they remove the virus, or even sometimes acceleration of this response can lead to the hazardous situation also. But after this, either the virus goes off and heart recovers, or some of that leading to the necrosis. So chronic inflammation lead to the necrosis and fibrosis, and that eventually the heart thins out and dilates and leading to the heart failure, and leading after 90 days, and then the chronic disease occurs, and that is chronic myocarditis. So what is the clinical presentation of myocarditis? So clinically, this myocarditis patient, they present as a acute coronary syndrome like presentation, like acute chest pain, frequently starting within 1 to 4 weeks of a respiratory or GI infection, and frequently associated with severe and recurrent symptoms, and there is angiography will be normal. So sometimes we have seen that in a patient who got a borderline troponin is mild or borderline elevated, and patient who got a chest pain, and when we do the angiography, there will be slightly sluggish flow or coronaries are normal, and LV is a little bit down like global 40, 50%, and after 1 month or so, patient got a LV dysfunction. So that kind of presentation will be there. And patient got a typical chest pain, and there may be ECG changes like T wave inversion, STT changes, or only T inversion, or with or without normal or global regional abnormality, and there may be RV dysfunction. So sometimes we have seen that tachycardiomyopathy, or sometimes initial myocarditis phase, only we see ejection fraction borderline down, global, angiography normal. So such kind of patient, they should be also be followed for the myocarditis. So after 1 month or 3 months, we should repeat echocardiography. We should not let the patient go. Of course, there your angiography is normal, you are normal. It's not like that. Such kind of patient can progress with the chronic myocarditis and lead to the DCM. And there may be, as I have told, there may be some elevation of biomarkers, and not like too much elevation of significant elevation like in acute MI, but they be mild to moderate or little bit elevation of biomarkers. Other patient, they present like new onset or worsening of the heart failure in the absence of CAD and non-case of cause of heart failure. Suppose patient non-case of heart failure, angiography is normal, patient already after 1 month or 6 month time, patient present with only heart failure. Patient come with a breathlessness, edema fit, chest discomfort, or the fatigue. There may be impaired systolic function or RV dysfunction or RWMA, and symptom possibly started after respiratory or GI infection, or patient postpartum. Suppose patient comes after delivery 1 or 2 months time, or within 6 month time, if the patient present with breathlessness kind of symptom, heart failure symptom, we have to suspect that peripartum cardiomyopathy or maybe myocarditis related to either autoimmune things or the viral infection. Or there may be non-specific ECG signs, Bundle block, AV block, or ventricular arrhythmias. Patient got an intermittent ventricular tachycardia, APCs, VPCs, sometimes PR prolongation, or RBBB or LBBB or AV block then can also be present. Some of the chronic heart failure in the absence of CAD, and there are some other things like heart failure symptom persistent, patient can present with fatigue, palpitation, dyspnea, atypical chest pain, arrhythmias, impaired systolic or LV or RV dysfunction, and when you do the MRI, there will be finding suggestive of ischemic cardiomyopathy or dilated cardiomyopathy, scanning, or late gadolinium inflammation like our thing, and non-specific ECG signs, and sometimes, as I have told, the bundle block or arrhythmias or the AV block. And some of the patients, they present with life-threatening, like as I have told, with cardiogenic shock, fulminating. So patient can present with cardiogenic shock with sudden history of life-threatening arrhythmias like VT, VF, aborted sudden cardiac death, cardiogenic shock, blood pressure 70, 80, patient is breathless and severely impaired LVD like 10%, 15%. That sometimes we see in pediatric population. So patient can present with cardiogenic shock also. So there are some of the diagnostic criteria for suspected myocarditis, and these are the criteria you can find on internet also. So clinically suspected myocarditis, if more than one or equal to one clinical presentation and more than one or equal to one diagnostic criteria for different category in the absence of angiographically detectable CAD stenosis more than 50%, non-pre-existing CVD or extra cardiac cause that could explain the syndrome like valvular heart disease, and if the patient is asymptomatic, more than 2 diagnostic criteria should be met. So which are the criteria? So clinical criteria: acute chest pain, pericarditis kind of pain, pseudo-ischemic, new onset, days up to 3 months, or worsening of breathlessness at rest or exercise, fatigue with or without left or right heart failure, signs of subacute or more than 3 months, worsening of dyspnea, so failure criteria, unexplained cardiogenic shock, And diagnostic criteria that include the ECG criteria. Sometimes we need a Holter or stress test also important to for LV dysfunction, QRS abnormalities, biomarkers like troponin T, troponin I, and functional or structural abnormality, that is most important. The imaging, cardiac MRI or PET scan, that is also helpful. Echocardiography, sometimes LV angiographically you can see RWMA, and tissue characterization, like patient may require a endomyocardial biopsy also for these things. And which are the lab reports you should get it done? So most of the patients, they should get a complete blood count. So you can see any allergic like absolute eosinophil count, ESR, CRP, liver function test, renal function test, electrolyte abnormalities, and of course troponins, serum BNP. So patient for heart failure, we should get anti-pro BNP or the BNP. And imaging wise, you should get a chest X-ray done, ECG, transthoracic echocardiography, cardiac MRI, get a T1 and T2 based imaging, that is also a must. And of course, in selected group of patient, endomyocardial biopsy. So according to this, you can define the patient on a criteria like low risk, intermediate risk and high risk based on the clinical situation, lab reports and ECG abnormalities and clinical presentation. In cardiogenic shock, you can define the patient as a high risk, low risk, intermediate risk group of patient. So these are the various criteria, even by investigation also, cardiac MRI, cardiac coronary angiography, PET scan, CT scan, echocardiography, endomyocardial biopsy, ECG. So all there are some criteria that can decide whether the patient falls into high risk, intermediate or low risk criteria. So what you can find on MRI? So MRI is one of the important tools readily available nowadays. You can see the global LV function. So global myocardial sign intensity increase in T2 weighted by image. So you can see myocardial inflammation, and of course you can see the late gadolinium enhancement also on weighted images. So what is specificity? So tissue characterization to evaluate the myocarditis. T2 weighted image shows the edema, and T1 weighted image the hyperemia and inflammation you can see, and late gadolinium image shows the fibrosis or the scar, and you can differentiate between the acute MI and or the coronary artery disease and myocarditis. How? So myocarditis, late gadolinium enhancement, there will be subepicardial to transmural, and there will be patchy enhancement in myocarditis, not related to the particular coronary territory. While in the MI, you can see the subendocardial, transmural and distribution in coronary perfusion like RAD, RCA specific territory is involved. And sometimes you require the repeat cardiac MRI after 1 to 2 weeks after disease onset if there is non-diagnostic cardiac MR initially. So this is how you can improvise your diagnosis, and specificity is 91% while the sensitivity is 67% with cardiac MRI. So which are the indications for the endomyocardial biopsy? Not routinely we are doing, but some of the cases we should advise, like severe congestive heart failure, not responding to our medical therapy, life-threatening ventricular arrhythmias, where we want to define certain specific cause. So in the context of recent onset of clinical syndrome, refractoriness to conventional therapy, exclusion of some of the other specific etiology like sarcoidosis, autoimmune disease, or some of the specific viral etiology, specific viral agent you want to give, absence of severe LV remodeling, suspected severe lymphocytic myocarditis, giant cell myocarditis, necrotizing eosinophil myocarditis, ventricular thrombosis, hypereosinophilic syndrome, drug hypersensitivity, and cardiac sarcoidosis with arrhythmias, AV block. So when you want to specify some things, you should do the endomyocardial biopsy. So there are some of the specific things where the endomyocardial versus cardiac MRI is helpful. So cardiogenic shock, sometimes the endomyocardial biopsy is more helpful rather than MRI. While the complicated impaired ejection fraction or arrhythmias, you can do the cardiac MRI. Or another thing is that persistent heart failure symptom, that both the things are helpful. So most of the things you have to specify certain things, and accordingly you should choose your investigation. And how you should approach to the case of myocarditis, how you can differentiate high risk and how you should treat it. So patient present with cardiogenic shock, Patient LV reduction is severe. Patient have got a life-threatening arrhythmias, acute heart failure symptoms, and all this group of patients, they are high risk group of patients, and these patients should be sent to the where the good cardiac care, tertiary care hospitals, like any good general hospital like UN Mehta kind of things, where every facility is available. So refer to that center and refer to the emergency, and of course we should get a cardiac MRI, and of course selected group of patients we should give a steroid also, or the specific therapy should be given. While the intermediate risk group of patient, of course there are acute heart failure symptom or mild symptoms where ejection fraction is good, but there are not hemodynamic compromises there. You can consider to the treat your center, and if required you can send to the specific center. Low risk group of patient can be investigated thoroughly, and they should be given medical management at your center also. So how we should treat myocarditis patient? So treatment response depend on the specific cause of the disease. If you know the specific cause, like acute viral illness, like COVID infection, so you should treat with antiviral agents. So any HIV infection, so if you find a specific agent like thyroiditis, you should treat with autoimmune things. Suppose the patient has got because of some drug toxicity like anti-cancer drug, you should avoid that thing. So if you find any parasitic infection, you should treat that. So any specific cause, patient should be treated accordingly. And irreversible tissue alteration is there, then it's a chronic process. We have to consider as a heart failure patient, and we should treat accordingly. So which are the various potential options and how we should treat it? So three things we have to keep in mind. There is inflammation is there or not. Active virus infection is there or not. So patient have got a no active inflammation, no virus. So it's the post-myocarditis, burnt out phase. So post-myocarditis, like LV dysfunction, no inflammation, biomarkers normal, then you have to go for symptomatic heart failure therapy like ACE inhibitors, ERNI, ARBs, diuretic, SGLT2 inhibitors, beta blockers, or some of these. If you find coronary artery, rule out coronary artery disease, treat accordingly. Patient, of course, is a dilated cardiomyopathy. We should take a genetic evaluation, and risk-adjusted therapy should be given. If the patient got active inflammation, virus is not there, and acute myocarditis, then if it is giant cell myocarditis, sarcoidosis, eosinophilic myocarditis, you have to go with the specific things. And patient have got suppose patient have got a cardiogenic shock, we have to give mechanical circulatory support. We have to put on IABP, ECMO, or impeller kind of device. That is also important, and we have to give. There is active inflammation, virus is absent, we have to treat them specific immunosuppressive therapy like the high dose steroid methylprednisolone, or we have to give azathioprine. So immunosuppression should be given. And patient got dilated cardiomyopathy, more than 3 months is there. If the patient got active inflammation, we should treat with the oral steroid like prednisolone or azathioprine can be given. And there is active inflammation as well as there is a virus. So inflammation and virus both are there. Like adenovirus, if you have got a specific antibody or specific test like COVID-19, we are getting the RT-PCR. So if there is active infection is there, and there is specific virus agent we can find like adenovirus, enterovirus, HIV virus, we have to treat that, and we can treat with either with the interferons also, or we can give a specific therapy like gencyclovir, acyclovir, valcyclovir, and no immunosuppression. And there is immune activation is there, so we have to treat with the interferon. And there is parvovirus infection, we have to treat with the immunoglobulin, and of course immunoglobulin is also one of the important, and immunoabsorption, that also I am going to discuss in next slides. So what is to be done in patient with patient came with a hemodynamic unstable, cardiogenic shock, fulminant myocarditis. So patient with life-threatening presentation should be sent to specialized centers where all the facilities like cardiac catheterization, where we can monitor the PA pressure, LV, we can put IABP, we can get a cardiac MR done, we can get a endomyocardial biopsy done. So that center we have to send the patient. So there it should be treated with aggressive therapy, so life support, and we can put on a ventilator, we can put on IABP, ECMO, or the impeller. So such kind of thing, and hemodynamic monitoring is also must, and we can stabilize the patient in such higher centers. And what about the patient with stable heart failure patient? As I told, if the patient got a LV dysfunction, EF less than 30, we have to treat as per the odd heart failure patient like Ernie group of drugs like Vimada, Sidmus or Asmida. We should treat like ACE inhibitors like Ramiprid, Enalapril, or we should, if the ACE inhibitor are contraindicated, we should treat with the ARBs like Valsartan or the Telmisartan kind of drug. And another important thing is NSAIDs agents such as indomethacin should be considered for patients with a myocarditis like syndrome of chest pain and normal or near normal LV function. So patient who got a pancarditis like pericarditis, we should treat with indomethacin. Other NSAIDs like ibuprofen should be avoided in sick patients. Arrhythmias, what should be done? Arrhythmias should be treated as per all other arrhythmias, like we should treat with the beta blockers, amiodarone, or patient got an electrolyte imbalance, we have to correct it. Hemodynamic imbalance, patient is very much hemodynamically unstable, we should put on ventilator or we should put a hemodynamic support like IABP or ECMO should also be done. So arrhythmia should be done either with a pharmacotherapy or with a mechanical support or ICD implantation as per the criteria. If patient is more than 40 days with arrhythmias, then survive after myocarditis episode, we should advise to implant a ICD. What about the antiviral treatment? If, as I have told, if specific etiology is found, we should do the specific etiology, acyclovir, gencyclovir, HIV specific or the COVID specific drug can also be given. And chronic viral heart disease, active virus infection is not there, but only inflammatory sequelae is there. We should treat with interferon beta also. What is immunosuppression? So immunosuppression is a demands a biopsy-based exclusion of virus from treated patient, since virus-positive patients do not improve upon anti-inflammatory treatment, while virus-negative patients with post-infectious autoimmune inflammatory process respond well in early clinical trials. So patient active infection is ruled out, only inflammatory process is there, we should give a immunosuppression. So immunosuppression in form of immunoglobulin, corticosteroid, azathioprine, cyclosporin can be given. Alpha-methyl prednisone like solumetrol is generally given in a dose of 1 mg per kilogram body weight, initially for 4 weeks, depend on the body weight. Another agent, azathioprine, is administered at a dose of 100 to 150 mg daily in addition to the corticosteroid, and steroids should be tapered when patient improves. And these are some of the immunosuppression therapy guidelines of the ESC you can get on a net also. What is IV immunoglobulin immunoabsorption? So we have seen in COVID that too much inflammation or too much immune reaction is also hazardous. So in that group of patients, we should try immunoglobulin immunoabsorption. So use of high dose IV immunoglobulin for treatment of acute myocarditis is associated with improved recovery of LV function and with a tendency to better survival during the first year after presentation. The rationale for immunoabsorption is to lower the cytokardiotoxic antibodies in the patient plasma, and with serial treatment over 5 or more days and extract the antibodies and immune complexes from the heart as well. So immunoabsorption removes all these combined antibodies and all these things from your blood. So IgG and to a lesser degree IgA and IgM are non-specifically adsorbed during the repetitive session. So session of the immunoabsorption is very helpful in active inflammation mode. So what about the children with myocarditis? So in children, several small studies with prednisolone plus azathioprine or cyclosporin without controls and often without biopsy or CMR evidence of myocarditis showed an improvement typically of LV function by echocardiography. So same as adults, you can treat the pediatric patient also. Although rare in children, other forms of myocarditis known to respond to immunotherapy include giant cell myocarditis, sarcoidosis, eosinophil myocarditis, and this form of myocarditis known to respond to corticosteroid based immunosuppression. So as the adult, you can treat the pediatric population also. So this is the flow chart as I have mentioned. So everything I have mentioned in the flow, that last 4 slides, the same thing you can treat your patient with specific things like chronic patient, active inflammation patient, and of course active viral infection patient in form of drugs or the antiviral drug or immunosuppression or the immunoabsorption ways. And how we should follow this patient. Suppose patient has recovered, how much patient should be called for follow-up? So patient as per the low risk, intermediate risk and high risk patients. So low risk patient at 1 month, 6 month and 2 year. High risk patient 3 months, 6 month, 12 month, then every yearly. So high risk also every yearly there should be follow up. Non-invasive testing, we have to get the ECG done, echocardiography if normalized between 1 to 6 months, then cardiac MRI once it should be done. Exercise restriction should be, yes, for 2 years they should not do competitive sports, but they can do normal rehabilitation process. And patient with high risk, lifetime exercise restriction is that they should not participate competitive sports. And of course, high risk, they should get a lifetime follow-up, at least 1 or 2 yearly echocardiography should be done. So briefly, so heart failure therapy should be started if LV dysfunction is present at presentation and should be continued for at least 6 months upon complete functional recovery. Suppose patient got a myocarditis, LV is 20%, recovered after 3 months time or 6 months time, but at least ACE inhibitor, beta blockers, that kind of therapy should be continued for at least 6 months upon functional recovery, and they should be followed up at least for 2 years. Immunosuppression for at least 6 to 12 months is required in acute myocarditis with clinical and EMB biopsy evidence of autoimmune disease including giant cell myocarditis, vasculitis or sarcoidosis, so that the prolonged immunosuppression should be given. Immunosuppression is not advised on a routine basis in acute myocarditis without clinical or biopsy evidence of autoimmune disease. So all patients of myocarditis DCM should not be given steroid except there is a inflammatory evidence. So initial empirical administration of steroid may be taken into consideration in case of high suspicion of immune mediated myocarditis, especially complicated by acute heart failure, malignant arrhythmia, high degree AV block. So you have got a inflammatory things are there like ESR is elevated, AV block is there, then or myocardial edema is there on MRI, you should give steroid. Intense sporting activities should be avoided as long as symptoms, cardiac enzymes are elevated or ECG imaging abnormality are present and at least for 6 months since complete recovery. Suppose patient recovered, then at least for 6 months they should avoid exercise, and some says up to 2 years heavy exertion should be avoided. And yearly follow-up for at least 4 years with an ECG and echocardiography is needed as acute myocarditis may lead to DCM in up to 20% of the cases. So stringent follow-up is required. So to conclude the today's talk, I want to say that acute myocarditis should be considered in patients of all the ages, including a pediatric population, with any of the following, like symptoms including the chest pain, fever or breathlessness, palpitations, syncope or cardiac arrest, prodromal illness, ECG changes, ST segment elevation, depression, T-wave abnormality, elevated cardiac biomarkers, regional or global contractile dysfunction of the heart, even if the angiography is normal. Detailed history and thorough examination are key to guiding further investigation for a potential etiology, with particular consideration is given to any recent current infections, autoimmune inflammatory condition and exposure to potential toxic substances. So suppose cardiologist does a echocardiography, don't send the patient home as it is. Take a detailed history and you can guide some specific therapy for each and every patient. Don't label every patient as a dilated cardiomyopathy. So take a detailed history. Cardiac MRI serves as a reference standard for non-invasive test for the myocarditis. It is one of the important tool, very easily available. Everyone should utilize it. Unless a specific cause is identified for which treatment is available and required, acute myocarditis treatment is generally supportive and focuses on the management of potentially associated complications such as heart failure and arrhythmias. We have seen that 80 to 90% of the patient treatment is supportive because either they present late or we are not able to diagnose some of the virus infections. So we have to treat with a supportive care only, and we have to treat the arrhythmias and drugs. NSAIDs, unlike with acute pericarditis, are not routinely recommended in the management of acute myocarditis, except endometriosis in cases like pericarditis or all myocarditis with pericarditis, pancarditis. Otherwise, only in rheumatic fever, pancarditis, should give the aspirin or endometriosis as I told, but NSAID like ibuprofen, such kind of drug or diclofenac should be avoided. Overall prognosis is good but can vary depending on type of the myocarditis and genetic abnormalities, with most of the patients recovering from their acute episode without long-term sequelae and with a low risk of recurrence. but stringent follow-up is required. However, dilated cardiomyopathy can develop in up to 30% of the individual with biopsy-proven myocarditis. So that we should keep in mind, and we should follow each and every patient of myocarditis for a prolonged period. Sometime peripartum cardiomyopathy or the myocarditis, once they recover, again that recurrence can lead to the again decrease in LV function. So they should be progressively or followed up every 1 yearly, 2 yearly. ECG should be done, and anytime suspicion is there, we should check with the echocardiography. Thank you so much.